In the continuation of infectious medicine, today I will discuss lung abscess. So first of all, we should know how we can define lung abscess. So we can define lung abscess as it is localized collection of pus and necrotic tissues within brain parenchyma caused by microbial infection. So infection by bacteria can cause destruction of lung and cause pus. There are two classification of lung abscess, that is primary abscess and secondary abscess. Primary abscess, it is most common up to 80%, while secondary abscess it is present up to 20%. Now primary abscess, it always occur due to aspiration. So primary abscess, it occur due to aspiration, and it is most commonly seen in comatose patient, in the patient of shock. Secondly, the primary abscess, it is always unilateral. It is very important. Primary abscess, it is always unilateral, plus it involves the right lobe and right side. Oropharyngeal bacteria are the cause of primary abscess. So oropharyngeal bacteria is the main cause of the primary abscess. And keep in mind, the oropharyngeal bacteria that are mainly anaerobic bacteria. So anaerobic bacteria is the most common cause for the primary abscess. So what are the most common anaerobic bacteria? Yes, that is bacteroides, that is Streptococcus and Fusobacterium. So these are classically anaerobic bacteria, that is bacteroides, Streptococcus and Fusobacterium. These are the main cause of primary abscess. If I talk about secondary abscess, so secondary abscess, it occur mainly due to lung neoplasm. It occur due to lung neoplasm, and neoplasm, it cause obstruction in bronchus and bronchiole and cause infection. Also, hematogenous spread of bacteria can cause the secondary abscess. So what are the organisms that cause secondary abscess? That are Staph aureus, mainly in IV drug abusers, Streptococcus pneumoniae, and Haemophilus influenza in unvaccinated child. Is clinical features of lung abscess. So if the abscess, it is less than 6 weeks, if the lung abscess that is less than 6 weeks, that is acute lung abscess. If it is more than 6 weeks, that is chronic lung abscess. Now this patient mainly it presents with the fever, because as it is infection, so patient presented with the fever, there is a spike of fever is seen, and there is productive cough. And the productive cough, there is foul smelling sputum, purulent or foul smelling sputum. It indicates the anaerobic infection. Also, night sweats due to abscess, there is pleuritic chest pain and weight loss. Location of lung abscess. The right side is involving more than the left side. If aspiration occur, in prone position or upright position. Then which lobe is involved? Then right middle lobe is affected. If the aspiration is in prone position or upright position, then in that condition right middle lobe is affected. But if aspiration occur in recombinant position, then in that condition it involves the posterior segment of upper lobe or the superior segment of lower lobe. I repeat, if there is aspiration in prone or upright position, then the right middle lobe is affected. If there is recombinant position, so aspiration mostly occur in the posterior segment of upper lobe or superior segment of lower. What are the diagnoses of lung abscess? So mostly the chest X-ray, it is the best initial test. Chest X-ray, it is the best initial test. In chest X-ray will tell you the, yes, it will tell you the air fluid level. It will tell you air fluid level showing the pus filled cavity. Showing pus filled cavity. So the chest X-ray, it is the best initial test and it will tell you air fluid level. But if I talk about the most gold standard, that is CT scan. So CT scan is most gold standard for lung abscess. We can do gram staining as well. Sputum gram stain in culture can be done. Management of lung abscess. So first of all, if the lung abscess is diagnosed, you have to admit the patient. Secondly, obtain sample for culture, and after that you should start the empirical antibiotic therapy. Right? If there is lung abscess, first of all you should admit the patient, you should take in the sample for culture, and then you have to start the empirical antibiotic therapy. So there are two conditions. If there are no risk factors of, if there are no risk factor for MRSA, and if there is a risk factor of MRSA. So if there is a risk factor for MRSA, then in that condition you have to give the stronger antibiotics. But if there is no risk factor for MRSA, in that condition you have to give mild antibiotics. So in that condition, first of all you should give the clindamycin 600 milligram IV 6 hours. This clindamycin, it kills the anaerobic bacteria which cause the lung abscess. Also we can give ampicillin sulbactam with the dose of 3 gram IV every 6 hours. Ceftriaxone plus metronidazole with the dose of 1 gram IV OD, and that is 1 gram IV BD. This metronidazole, it also kills the anaerobic bacteria. Also we can give moxifloxacin with the dose of 400 mg IV per orally OD. So if there is no risk factor of MRSA, in that condition you can give clindamycin, ampicillin sulbactam, and ceftriaxone plus metronidazole and moxifloxacin. But if there is the highly risk of MRSA, then in that condition you have to give the stronger antibiotics, and that is linezolid. In this condition you can give the linezolid with the dose of 600 milligram IV BD, or you can also give the vancomycin. You can give the vancomycin with the dose of 15 to 20 mg per kg every 8 to 12 hours. Intervention therapy. Usually the lung abscess, it does not require any interventional therapy. We can treat the lung abscess through empirical antibiotic therapy, but by any means, if the size of lung abscess is more, then in that condition we can consider the intervention therapy. So if the lung abscess size is more than, if lung abscess size is more than 6 to 8 centimeter, then we can consider the intervention therapy. If there is significant hemoptysis, or if there is significant hemoptysis, then we can consider the intervention therapy. This hemoptysis, it indicates the severe lung infection. So in that condition, we can give the intervention therapy, or if patient is not responding to empirical antibiotic therapy. What are the first line intervention therapy? What are the first lines intervention therapy? The first line intervention therapy is bronchoscopic drainage, or percutaneous drainage. So the first line in the intervention therapy, that is bronchoscopic drainage, or that is percutaneous drainage, while the second line is, that is surgical resection or lobectomy, when lobe is removed, and pneumonectomy, when the whole lung is removed. So student, that's all about the lung abscess.